So first, I'm going to go through the protocol of SpineMED in that the wide variances of patient suitability, indications and contraindications. And the indications, of course, are disc pathologies, and virtually any disc pathology is applicable with SpineMED, whether it be degenerative disc disease, disc bulge, herniation, prolapse, even sequestered fragments we found to resolve through SpineMED. So secondary symptomology and pathology such as lateral foraminal stenosis, facet arthrosis, mechanical back pain, are secondary typically to different disc pathologies, primarily disc degeneration. And all of those conditions resolve very, very well with SpineMED, and typically above 85% success rate with SpineMED. So the indications, if you know of any underlying disc pathologies, those are applicable. With contraindications, they're essentially instabilities of the spine, fractures less than 6 months of healing, bilateral pars defects, spondylolisthesis above grade 2. You can treat a full grade 2 spondylo, but you would probably be a little more cautious with the tensions and how you increase tensions with the patient. Spina bifida and neoplasms, of course, any cancer in the, so anything in the spine, and of course, surgical hardware implantation. As a manufacturer, that we have to, for liability purposes, rule out surgical hardware implantation as a contraindication. And so once you've ruled out contraindications, and what we found clinically is that patient suitability has a much wider spectrum with SpineMED due to the low force requirements. Now, when you look at every other device other than SpineMED, the capture of the patient is through nylon harnesses that capture the lower trunk area of the patient. And with the high forces, their lower margin capture is usually insufficient. They slip through, and so the patients are restrained with axilla bolsters. So when you look at the application of force on those devices, there will be an electric motor inside the tower or inside the box at the end that's then connected to a seat belt or even a rope. So you might have 15 to 20 feet of nylon strap or rope that then connects to a nylon harness. So the delivery of energy on these older technologies is very rudimentary. It's like old traction technology. And so the force is applied through the entire torso to eventually cause some form of distraction force in the spine. And so with those devices, because the force is being distributed through all that adipose tissue, through fat, muscle, ligaments, even organs, to eventually cause distraction in the spine, they require a much higher force than what you would find with SpineMED, in that their protocol is typically between 55% and 75% of body weight. Now, SpineMED has a unique patented system, pelvic restraints and cervical restraints. Now, while these look like they're a clamp that clamps against the pelvis, they are not. Nylon harnesses, of course, clamp the entire trunk, the lower torso. And because the harnesses often slip off, you'll find that practitioners using these devices will have the harnesses so tight on the patient to try to prevent them from falling off that they apply a significant force in the hip joint. And there are actually lawsuits against these harness-style machines where they've caused hip joint bursitis from those harnesses being so tight. So conversely, SpineMED's unique system, these pelvic restraints, again, are not a clamp. They're shaped to conform to the top of the iliac crest, and they sit at a 20-degree angle so that they comfortably rest over top the iliac crest, and are padded with 5/8 of an inch of gel padding. So they're very, very comfortable. And again, they don't have to apply any pressure against the pelvis. They simply rest over top of the iliac crest. And when you look at the delivery of energy, SpineMED is unique in that these metal restraints are directly connected to the drive mechanism. This is a split powered table system in that the electrical actuator is directly connected to that sliding frame. So the delivery of energy is metal, metal, bone. So we bypass the delivery of energy to all that soft tissue, adipose tissue that other machines apply. And so with direct application of force to the spine, SpineMED requires typically only between 10% and 15% of body weight for lumbar treatment. For cervical treatment, it's anywhere from 4 pounds to 12 pounds typically for patients, either male or female. So the common side effects with all other harness style machines are gone with SpineMED. And you'll find with harness style machines that use, for instance, my treatment on SpineMED is 26 pounds. My treatment on a device like DRX, any other harness style machine, is 125 pounds. So side effects are very common on those devices, in that if patients have any thoracic issues or previous injuries, you'll flare them up. And patients typically worsen before they get better on the harness style machines. That's how we were trained when we owned those machines back in the 1990s. And it's true. Patients first worsen before they get better with a harness machine. With SpineMED, because we have direct application of force directly to the spinal structure, there is very little force required. Again, typically 10% to 15%. And patients should not feel the treatment. Now, if during the protocol you increase tensions to find out what the subjective treatment parameter is for this patient, when you exceed it, patients will feel discomfort, a soreness centrally above S1 in the spine. And that's our indication that we've caused an inflammatory response due to excessive tensions. So number one, patients should not feel anything during the treatment. They may feel the split table move, and so movement of the table, but they should feel absolutely nothing in their spine. If they feel something in their spine, again, it could be a sensation centrally above S1, which would be either a warm, tingly sensation, something the size of a silver dollar that just becomes warm and tingly. That's our indication that we're causing an inflammatory response on the annulus. And so you need to back that off. So clinically, for patients, any one of us that have gone for any other type of treatment, there's very few, if any, treatments that we go to where you're not supposed to feel anything. And so for patients, the patient education is paramount in that, especially male patients, when you put them on the device, they don't feel anything. We are all conditioned to where the more I can take, the better treatment I'm going to receive. And that's completely contrary. It's contradictory to SpineMED in that if they feel something, we are causing an inflammatory response when we're trying to reduce inflammation in those levels. So educating the patients that if they're sore after a treatment, or if they feel that sensation during a treatment, we're causing an inflammatory response. We need to back off the tension so that you don't feel anything. And this, of course, is why there's a patient monitor. As you can imagine, our first device actually that was introduced in 2000 did not have the patient monitor. And so clinicians were calling us up saying, listen, Tim, the patients are calling me back. They're on the machine 3 or 4 minutes. They call me back, say, listen, you forgot to turn it on. It's not doing anything. So we added the patient monitor primarily for that function so that the patients then can see the digital trend line graph and psychologically understand, okay, the machine's turned on, but I don't feel anything. So that's the primary purpose of the patient monitor. And it, of course, does play videos and so on. So the protocol, the SpineMED is all electronic patient charting. Once you have a patient's chart in the system, the software will calculate starting treatment protocols for every patient. With lumbar, as I said, we start at 10%. And the only time you would alter that is if you had a very frail patient. The oldest patient we've had on SpineMED that I'm aware of is 96-year-old in Brazil, a 94-year-old in California, and a 92-year-old in Eastern Canada. So you can treat a huge spectrum of patients on the device. On an elderly patient like that, I would probably start them a little lower than 10%, so you can manually alter the max tension. And the formula is very simple, the protocol, in that we're trying to find the subjectively perfect tension for this patient. And so each day we gradually increase. And of course, during the first session, When they're on the device, we verify, do you feel any sensation centrally above S1? If they do, we back it off. If not, we continue the session. Each day that they come back to the clinic, we verify, did yesterday's session cause any soreness centrally above S1? If yes, we need to back off tensions. If no, we gradually increase. Depending on the patient, anywhere from 1 to 3 pounds. So if it's an elderly patient, you might only add 1 pound. If it's a younger, healthier patient, you might add 2 or 3. And so at some point, as you titrate up the tensions, at some point, they're going to come in and say, yeah, I was sore for an hour after yesterday's treatment. And then you know that, okay, we've exceeded their subjective tension for lumbar treatment. And similarly with cervical, cervical is different in that it's a broad, diffuse discomfort that we create. And with lumbar, again, it's centrally above S1. And so once you reach that point that we cause soreness, you need to back off to where the patient is not sore during the treatment. And so during the treatments, what you'll find, we say that there's a minimum requirement of 20 sessions, 20 daily sessions. And clinically, what you'll find is that the more frequent you treat patients, the better your results and outcomes will be. In that, while they're on the device, of course, they're having a 30-minute treatment where we're promoting the influx of fluids, nutrients, and oxygen into the disc. And then the other 23.5 hours, they're causing a loading of the spine. Now, throughout the day, we can lose up to 20% of the hydration in our discs through just normal loading of sitting, standing, walking, and so on. And as you know, the change in pressure in the discs changes dramatically depending on body position. Standing vertically, it's about 100 millimeters of mercury. When we're sitting, 200 to 275, depending on how we're sitting. If we lift something incorrectly, it can be up to 600, 700 millimeters of mercury. And especially when we're bending forward, lifting something and then rotating, you're causing that pressure on the disc where the anterior is pushed down and the posterior is kind of blown out. And so when you rotate that, you cause torsion in the annulus. And that typically will result, depending on the pressure, of course, it'll result in tears in the annulus, annular fissures. And as we know, annular fissures really never heal. Patients may become asymptomatic over the years, but radiologists will tell you that fissures never heal in disc annulus. And of course, once the disc annulus is compromised, you end up allowing the disc wall, the annulus, to bulge outside its normal area, thus creating bulges, herniations, prolapse, and even then sequestered fragments, depending on the degree of compromise of the annulus. And so the body's mechanism to provide nutrition to the discs is really flawed because the discs are avascular. They don't have a blood supply for nutrition. They rely on osmotic diffusion. And so when we get our 10 hours of perfect rest at night, pressure in the discs when we're laying supine or prone is approximately 75 millimeters of mercury. And that's only under ideal circumstances. That's if we don't have an injury that the body's then guarding and protecting and locking up that segment. And so under ideal circumstances, the differential in pressure is only about 5 millimeters of mercury diffusion. So pressure in the discs, again, ideally, under ideal circumstances, can be as low as 75 millimeters of mercury, and diastolic pressure about 80 millimeters of mercury. So that influx is primarily across the end plates of the disc from vertebra above and below into the disc. Because throughout the day, as the discs are compressed, that water content, hydration, is primarily expelled across the end plates into the vertebra above and below. And then when we get our rest, there's that slight influx. So because that differential is so low, that disc degeneration is common. Every human on the planet is going to suffer from some degree of disc degeneration. And then the nutritional transfer, as we age, the discs degenerate, they lose their height, they changes in hydrostatic pressure, pH balance, and so on. The disc environment actually becomes a dead environment. We lose the proteoglycans in the disc. The proteoglycans are the building block of the disc nucleus that hold the water molecule. And as those diminish, the nucleus therefore can no longer hold water molecules, and the discs dehydrate, degenerate, and then, of course, disc height also is compromised. And once we lose disc height, And of course, you end up having mechanical pressure on the facet joints. Facet joints become pathologic and can cause that mechanical back pain. In addition, with loss of disc height, we lose space in the foramen, and then nerves can be impinged due to inhibited space in that recess. So decompression is designed to increase intervertebral space. So in applying a distraction force to the spine to increase intervertebral space and unload the discs. Now, when you look at some of these other technologies and you look at how the force is applied, again, with a nylon harness style machine, you're applying force through all of that soft tissue to eventually cause distraction in the spine. Now, the technology of decompression is such that it's designed to bypass the human neurological response so that when you're distracting the spine, you don't fire the paraspinal muscles and ligaments, which would then counteract increasing intervertebral space. With a harness style machine, I think it's quite questionable as to their ability to bypass that human neurological response because of the amount of force being applied through all of that soft tissue, including muscles and ligaments and the paraspinals. And I would suggest that some of those machines with very, very high force do recruit paraspinal muscles and ligaments. But in using high forces, for instance, 125 pounds on a guy like me, they tear past that muscle and ligament recruitment to open up intervertebral space. So with SpineMED, because we are directing force directly to the spine with a very small amount of force, and with our computer control, which I'll get to, we're able to bypass that neurological response, and then with a very, very small force. Again, some females we treat at 15 pounds, 16 pounds of force, which is a small amount, which you could exert more just by pulling with your arms. So we're able to unload intervertebral segments with a very small force. And what research has shown with SpineMED, specific SpineMED research, pre and post MRIs, and a number of different studies using different protocols, that we're able to actually restore hydration in the disc. There is a study done in Italy, a Decompression protocol, where pre and post MRIs were taken using 3 times normal gadolinium in the patients, very, very high contrast, using a 3.0 Tesla machine and specialized software that was able to demonstrate proteoglycan content in the disc. And these slides show that there's been a restoration of proteoglycan in significantly degenerative discs and even in what would look like black disc vacuum phenomena. This has never been shown through any other mechanism whatsoever. Only SpineMED has been able to demonstrate this scientifically, the restoration of proteoglycan content in the disc so that the actual nucleus then becomes a healthy environment, is able to absorb water molecules and hydration. So it's profound in those differences. Now, as well, the mechanism of action, when you look at distraction of the spine, so if this spine is laying flat in a perfect horizontal condition, when you apply distraction force to the spine in that manner, the greatest amount of distraction force is at L5S1, and then it gradually diminishes up the spine in that flat linear pull. And so if you're trying to treat the most common level L4-5, you actually have to overtreat L5S1 in order to get significant distraction at L4-5. Now, with SpineMED, once you have the patient captured and on the device, the patient here, the practitioner selects which level you wish to treat. So for instance, if you want to treat L4-5, select L4-5, and the system places the patient's pelvis into 10 degrees of flexion. Now, in some of the more sophisticated harness style machines, you'll see that they raise and lower the seatbelt relative to the pelvis, which is their mechanism for moving the focal point of distraction force. That does place the pelvis into some degree of flexion, but the problem is, it's simple physics. The steeper that seatbelt angle becomes, the more force is used to lift the buttock off the table and not distract the spine. For instance, at 90 degrees, you would simply be lifting the patient's buttock off the table and you wouldn't be applying any distraction force. So their device can be quite inefficient. And even at 30 degrees, you're probably losing 33, 34% of the distraction force to simply lifting the patient's buttock off the table. With SpineMED, it's all automated, computerized in that when you select the angle you want, we rotate the pelvis into whatever degree of flexion that is appropriate for that patient. And so 100% of the distraction force is in the distraction plane. There are 4 sections of the table that all move simultaneously. It's a powered split table. So with the patient, they're fixed to the fixed section of the table. We capture the lower margin of the rib cage, fix that to the fixed section. There's a far infrared element in the lumbar section of the table with an inflatable air bladder so that we can support the natural lordosis, because the lordotic curve during distraction tends to flatten out and cause discomfort for the patient. So within that inflatable air bladder system, there's also a far infrared element, 908 nanometer wavelength, that has about a 35 millimeter penetration depth that's designed to reduce inflammation and speed healing through photobiostimulation. So these sections all move simultaneously and are controlled by the computer in the table. And how the SpineMED works, this computer, it's an all-in-one medical grade touch computer that houses the SpineMED software, this patient database, and then all their records, all the patient records. It's password protected so that users can be assigned by the clinic owner, so that only authorized people that have been trained on the device then have access to it. And the patient records, once we enter in a patient record, then of course you can treat them in either lumbar or cervical. And there's different parameters that we can use for comfort. Now, some of the things that can change the variables. So with SpineMED, we have the ability to allow the patient to make adjustments so that the treatment is subjectively perfect for them. So for instance, if you look at a harness style machine, one of the primary issues with the harnesses, not that they're cumbersome, they're time consuming to put on and so on, but they change the treatment sensation if they're tighter or looser or higher or lower. And what we found in our clinics is that if you had different therapists treating the same person, from one day to the next, the harness would feel different. It would be higher, positioned higher, or maybe a little tighter or looser. And when they're on the device, the treatment feels different. And as we know, when something is different from one day to the next, one was right and one was wrong. So repeatability of treatment with harness style machines is very, very low, and it's very difficult to have that repeatability so the patients are getting the same experience. With SpineMED, many of the variables patients are in control of. So once we have the patient on the table, we show them where these restraints are to be positioned. So they move themselves around on the table to where they know it's in the same place every time. And the adjustment wheel is within their reach. And so we instruct them to adjust the tension of the positioning of the restraints and how firm they are against the top of the pelvic crest. So that's the same every time. When the patient's in control of those 2 primary variables, reproducibility is virtually 100%. Now, during treatment, what we like to do is change aspects of the treatment so that it's subjectively perfect for the patient. So once a treatment is started, after the 4.5 minutes, after the cycles of progressive cycles have gone through, it's about 4.5 minutes as the machine gradually ramps up to your max tension. Then we adjust, I pause the session, and I'll change the angle. And in that, rather than using some objective data that your most prominent levels, L4, 5, you're going to get 10 degrees, I prefer to adjust it to find out what the patient prefers as the most comfortable angle. 0 degrees isn't comfortable for many patients, even though that would probably be the most common level where you're trying to treat L5S1, L4-5, and L3-4. The base levels, if you have pathology at one level, there's typically something going on at the other 2 levels as well. And so 0 degrees is kind of the protocol. However, I found that if you start a patient at 5 degrees, run it through, so that they have at least a couple cycles of max tension at 5 degrees, pause the session, try 10 degrees. And you'll find that more than 90% of the patients are going to prefer either 5 or 10 degrees. They're going to find that the most comfortable. And of course, you can try 0, you can try 15, but I would say that that's very rare that you would find a patient that finds 0 degrees or 15 degrees more comfortable than either 5 or 10. And so we base it on subjective preference rather than some data off a chart. And that way, the patients then have a much better experience in the treatment. Another variable is, so if the patient's uncomfortable in the treatment, change the amount of air in the air bladder. And again, this is positioned where the patient can adjust it themselves. They can inflate it or deflate it. So during the treatment, they have the ability to increase the pressure on their lordosis or decrease it. Another variable is the knee bolster. Some patients prefer their heels to be off the table. Some prefer to have them on. And so this bolster, it's another patent of ours. It's adjustable by simply rotating it 50, 60, 70 degrees so that you can accommodate different leg lengths with that one bolster. The head cushion is also adjustable, either 1 inch, 1.5, or together 2.5. And we do that with comfort. With patients, you don't want their neck elevated too much biomechanically, but we also want them to be comfortable. So you find a happy medium so that they are always comfortable with the device. So those are a lot of the parameters that we can adjust with the device to make the treatment far more comfortable. And comfort's key. Now, mechanically, in use of the device, I'm not going to bring the camera to the other side, but I'm going to talk about the power on and power off part of the system. In that, on the far side of the table, on the back side, there's a power inlet. Let me see. Yes, we can see this. So there's a small module. It's a power module that has the power cord inlet, which is at the bottom. There's a fuse holder in the center, and then a small switch, which is the main supply to the whole table. The way this works, that main switch, that small switch on the side, should be left on all the time. The only time you would turn that off is if you're going to unplug the unit from the wall. Because there is a very large toroidal transformer, an isolation transformer in the device, if you have that switch on when you either unplug it or plug it back in, you can create an arc, which then may blow the fuses. So if ever you're unplugging it from the wall or plugging it back in, you want to ensure that that switch is off and then turn it back on. That switch is left on in that it provides power to the UPS. And so the batteries in the UPS are consistently being charged, because the UPS should be turned off each night. And let me get the right photo here. So the UPS is positioned the front center of the machine, the center button. You press and hold till you hear the beep, let go, and you'll hear the second beep, which is an indication that the PCB inside the table, the computer table, or computer in the table, has power. And that's just an indication that we put in there so that for troubleshooting. This is a blurry picture of the UPS. As you see in there, it's a digital readout. That's the center power button. There are other buttons then to go through the digital menus so that you can diagnose it and so on. The indicators here, the battery indicator shows the amount of battery life left in. It will show how many minutes of runtime it has built in if it was on battery backup. And if the device beeps at all, if there's any beeping in the system, you have to find out what it is. It's an alarm code. And with the SpineMED, if the power is interrupted, the UPS will alarm. And that's an indication that you need to find out why there's a power interruption of the device and shut it down. The UPS is designed to run a little over an hour, and it's there so that you can finish and complete a treatment if in the event of a power failure. So you can safely finish a treatment. It's not meant to run all day if you have a power outage in the city or something like that. It's just to finish that one treatment so that you're finished with that. So once we have the system turned on, We turn on the primary computer. It runs on Windows in the background, and then it loads our proprietary software and the SQL database that houses all of the patient data and their records. So in the positioning of patients on the table, these should be, as I was showing here, just over top of the iliac crest. So positioning is such that we would position the top of the crest in line with the restraints and the shaft that hold the restraints. And you'll see that there are adjustment holes in the restraints. There are 3 separate holes on either side of the device. And these operate in a uniform fashion, and they're bilaterally moving in and bilaterally moving out so that the patients are perfectly centered. The important aspect of which holes you choose to use so that we can accommodate any patient is that whichever hole the restraint is in on one side, it has to mirror the other side. So if it's in the middle hole on one side, it has to be in the middle hole on the other. So that confirms that the patient is centered on the device. When we look at patient size, now through all of our certifications and testing in the operator manual, it states a 325-pound patient. And the reason for that is that whatever number we come up with in the operator manual, they test the machine at 4 times our claimed weight limit. And so this device was tested at 1,400 pounds on top of the device without any problem with even the cushions or anything. So it's been tested at 1,400 pounds, and I would suggest if you have a 1,400-pound patient, you're not even going to get them into your office. So there really isn't a weight restriction on the device, although the manual does state a maximum of 325 pounds. And I've personally seen a patient 525 pounds on the machine. Interesting to get them set up. You'll find that these restraints will find their way to capturing the pelvis. Even though you may have 5-6 inches of adipose tissue to get through, they're magical in that way in how they can actually capture a patient. So let me show you patient setup. I'll have a demo fellow here. Thank you, Bhavya. So you have the patient sit here, okay, and then lay down. And so again, we position them so that the iliac crest is centered midline with that restraint mechanism. And put one in. Okay, so we palpate to the top of the crest, down just a hair. Perfect. These handles, by the way, if you pull out, pop in, they move out of the way for patients getting on and off. You just pop them out. Be like that. Okay, and I'll have you adjust it. It's easier on the top. Okay, does that feel? Okay. The upper harness, what is the most common mistake is that these are simply placed laterally. They're designed to go in a crosshatch. So they should be in an X pattern. Beneath the lower margin of the rib cage, you want them to at least have half of the restraint below the lower margin. The knee bolster, we adjust to their leg length, whatever's comfortable. Okay. The air bladder, if you want to fill this to its comfortable, typically 2 or 3 pumps is all you need. Okay, how's that feel? You good? Select the patient from the database. You turn on the infrared heat if the patient wants it. It's very rare that a patient doesn't want the far infrared on. It's very, very, very subtle, low wattage. And so start at 5 degrees of inclination for a patient's first session. So once we have the patient in there, and we have on the Ultra model, we've incorporated into the electronic patient charting, notes, and daily VAS index. So we can add in the patient's daily pain scale, 0 to 10 each day, so that we can track that. That becomes a record in their chart. And we have notes built in as well. And as a clinician, you have the ability to put in an unlimited number of templates of treatment notes. Now, typically what you'll find is probably 40 or 50 different common notes that decompression patients you'll have for them. And these notes can be one sentence or they can be 25 pages long. So once you enter in your common notes, and we used to do this, but then doctor said, oh, I want you to change this, I want you to change that. So we said, you guys do your own notes. And so once you've entered in your own notes that are particular to your style, they're there forever for every patient. And so doing your notes rather than doing them in the evening or on weekend, you can have a very comprehensive note in the system where you simply select a particular note. And so your notes are done in a second. You press start. The patient then verifies that they're okay to start, and then they're in control of the treatment. They press the button once, and it allows the practitioner then to start the treatment. For safety, the patient's in control of the treatment all the time with that patient safety switch. In addition, for liability purposes, if a patient ever said, oh, you hurt me, they're in control of the treatment. They start the treatment, or they allow the start of the treatment by pressing that button each and every time at the beginning of the treatment, and then they have access to stop the treatment. So if ever they had discomfort, they're in control. That's primarily for liability purposes more than anything else, because again, if patients don't even feel anything on the device, side effects that are common, again, with harness style machines, they're gone with SpineMED. They just don't happen. So we allow the system then to ramp up to its full distraction force. There are 3 progressive cycles. Now, each cycle on the device consists of 60 seconds of a maximum tension, followed by 30 seconds of relaxation. So that accordion effect of drawing in fluids, nutrients, oxygen, water back into the disc, relaxing somewhat, not to 0, but relaxing at 50% of the max. And each cycle is 90 seconds. So 60 seconds distraction, 30 seconds relaxation. And there are 3 cycles on the lumbar treatment that it gradually ramps up to the max tension, so that we're not immediately going to max tension with the device. We're gradually increasing that tension. That's part of the formula in bypassing patients' reflex muscle contraction. And SpineMED is, again, very unique in the marketplace in that how SpineMED works and how its ability to adjust tensions is unlike any other machine. Once we press start on the primary computer, it sends an algorithm to the computer in the table. The computer in the table then takes over, and it applies a specific algorithm for this patient based on their patient body weight. And every 2.5 milliseconds, it will verify the tension being applied to his pelvis against that algorithm. Samples that 8 times, and so every 20 milliseconds, if that number is outside parameters, it will make adjustments. And so this feedback loop system in the device is designed to be faster than the human neurological response, which is about 50 milliseconds. We're able to adjust every 20 milliseconds because we have direct capture of the skeletal structure. And again, the application of energy is metal, bone. It's virtually instantaneous, the ability to adjust. Now, devices with harnesses and seat belts attached to the patient, they say, well, we can adjust in 1 millisecond. The electronics in their machine possibly can make that adjustment, but physically, when you look at that mechanism, the physical mechanism where they adjust the tensions, the computer may adjust every 1 millisecond, and then it tells their motor to either turn clockwise or counterclockwise, power a large drum through a chain, and then the drum will turn clockwise or counterclockwise to let more seatbelt out or bring in seatbelt. That adjustment is measured in seconds. You can watch the belt slowly move out and slowly move in. So while their electronics may state that they adjust every 1 millisecond, the actual physical phenomena is measured in seconds in what they're changing. So SpineMED there, again, is unique in the marketplace in its ability to adjust. So now, once the patient has had a full max tension treatment cycle, We wait for it to go into the relaxed cycle. We press pause. This allows us to change the angle either up or down by 5 degrees and also modify the tensions. So if the patient is finding that the tensions are causing that discomfort, the first thing I will try is changing the angle. Many times if a patient is at 10% when you're starting them and they do feel that sensation, that tingling sensation above S1, if you alter the angle, 9 times out of 10, that sensation will go away. So you may not have to lower the tensions. That's the first thing I would try. And if the sensation's still there at a different angle, then definitely you lower the tensions. We allow the system to cycle back up so that they have a full max tension cycle. And we ask the patient, do you prefer this angle or the previous angle? This one's better? Okay. And you'll find that regardless of the level of pathology, they're going to prefer one specific angle. And it's usually 5 or 10 degrees, sometimes 15, rarely 0. I have never taken a patient up to 20 degrees or 25 degrees. Although it targets up L3-4, L2-3, patients find it uncomfortable, even though we can target that specific level. So again, we go by patient comfort and not by using some objective chart. We let the treatment progress throughout. Once we find their target tension that's subjectively perfect for them, and then it's completely unattended. Setup time with the device is about 90 seconds, and it is truly unattended. The pelvic restraints, once we have them positioned on the patient's pelvis correctly, it's physically impossible for them to slip off. Nylon harnesses slip off all the time, and that requires practitioners to be at or near the machine throughout the entire treatment process to monitor and make sure that the harnesses haven't slipped down or there's another problem with the device. With SpineMED, it's unattended. Typically, we put them in a separate room, close the door, turn the lights down, and patients will fall asleep. 80% of patients will fall asleep if you have it in a room where the lights are dimmed and it's quiet. So at the conclusion of the treatment, just wait for relaxation phase. I'm going to cancel it early so that we can demo this. So the SpineMED, again, it operates for the full 30 minutes, automated. It's a 30-minute cycle. And at the end of the cycle, when it concludes, it will beep one time, an audible but not obnoxious beep, so that you as a practitioner can hear it and come take them off. And wind the restraints. Take off the upper restraint. Hang on, don't get off yet. I know you're excited. With the restraints out, we then lower the angle back to 0 degrees. And the cushion, have them roll over to their side and sit up. Now, the big difference between lumbar and cervical treatment is that with cervical, we first do the angle. You would never adjust the angle of the cervical tilt with the patient on the device. So that's the primary difference. Now, with the cervical restraints, they are fixed into several different holes. There are 3 holes on either side. What you'll find the most common width for most patients is that you will have one restraint in the middle hole and the other restraint in the closest hole towards the patient. Proper positioning of the restraints is such that if they're too wide, you'll find that they're stretched out over top of the patient's ear. If it's too narrow, it's going to be on the neck. We want it on the mastoid, on the back of the occiput, so that we're capturing the skeletal structure. So here, restraints in. Here again, we first select the angle. Now, with the cervical spine, we cannot pause and change the angle midstream. You can pause the cervical treatment to adjust the tensions, but not the angle. You can lift the patient off, but you would never adjust the angle with the patient affixed to it, because you can apply a distraction force not knowing how much that distraction force is. Okay, lower this down a little bit. So have you move up here a little more, please. This rotates, the computer arm moves out of the way. We guide the patient down. Over to your right a bit. There we go. Now, typically, there's head straps. I leave the far side with both straps attached, and then I only put in one side on this side. The strap isn't there to hold the head down. It's to simply prevent it from lifting. As you apply distraction force, the occiput, it just tends to lift the forehead slightly. So it doesn't require a very high force. Lift your knees. There we go. Air bladder. Patient safety switch. Start. Go ahead and start. Thank you. Here again, automated, it gradually ramps up over 2 progressive cycles to get to the max tension. We monitor the patient throughout this, and here, if they find the tensions have been too high, they will have that broad diffuse soreness, either during the treatment or after. If they're sore after the treatment, we drop the tensions. Typically, we start females at 4 pounds, gradually increase 1 to 2 pounds a day. And typically, there's a wide range of physiology with patients, but typically females anywhere from 5 to 9 pounds, usually. Men, we start at 5 or 6 pounds, and typically you're going to see between 9 and 14 pounds, perhaps, unless you have some NFL football player with like a 30-inch neck, then you might get up to like 20 pounds, 22 pounds. It really doesn't require a lot of distraction force for either lumbar or cervical to provide adequate distraction of the spine. Okay, what have I missed? Devices, the harness machines that we had in our clinic. We found that once you found that proper tension for a patient, due to the immense end of stretch of muscles and ligaments in the lumbar spine, number one, with the high distraction force devices, after 2 or 3 treatments, patients have real instability in the low back. And this is why they insist that patients wear lumbar support belts. And we found that even though after 5 or 6 sessions, 7 sessions, you may find a suitable treatment tension for them, that after 10 to 15 sessions, that would become too much for them. Because again, muscles and ligaments through high distraction force become very lax. And so that same amount of force is causing even more distraction in the spine. And so we'd have to pare it down. With SpineMED, once you find a patient's ideal or subjectively perfect tension, you would leave them there. And you monitor them. And again, every day you ask them, did yesterday's session cause soreness centrally above S1 or broad diffuse in the cervical spine? And so usually in 95%, 98% of the patients, you're going to find that that tension's fine. Where you may need to adjust it is if young guys, they're the perfect patients, that they start feeling better. So after 2 weeks of treatment or something like that, I'm going to go out golfing. I'm going to go out downhill skiing. And they feel good. And so they go out and engage in activities too soon. And so they sometimes flare themselves up. And in those cases, we find that you may have to drop the tensions down a little bit in order to allow that healing time, because they're a little bit exacerbated, they're inflamed. And that's the usual time I'd suggest with SpineMED that you may have to adjust tensions down. Did that answer that? Yes. Any surgical hardware implantation in the spine is a contraindication. The studies that were done back in, published in 1994, Journal of Neurosurgery, with the original device VAX-D, they were able to demonstrate a reduction of intradiscal pressure to minus 150 millimeters of mercury. And so then the diffusion gradient, the differential between the surrounding bodies and the disc, is more than 200 millimeters of mercury. And so the research that's been published with SpineMED, it supports that reduction of interdiscal pressure to the negative range, where you're dramatically drawing in water, oxygen, prolate, substrates back into the disc and actually changing the health environment of the disc. We've seen reversals of what would be dead phenomena within the disc nucleus to where it's again a healthy disc. Increasing disc height, that's shown on plain film all the time. Sequestered fragments. There's a study done by a doctor in Azerbaijan with SpineMED pre and post MRIs. And there's like 20 or 22 patients with sequestered fragments. They're all sequestered fragments and they all resolve with SpineMED, which doesn't make sense, but it's hard to argue with that objective data with those pre and post MRIs. But in Germany, more than 220 spine surgeons have SpineMED in their office. So that if you're a disc patient that come to them, they're very conservative. You know, they will operate on a very small percentage of patients that come to them for consults. And so for the other patients that are not good surgical candidates, they put on SpineMED. So 90% of the patients they see, they put on SpineMED. If SpineMED doesn't resolve the issue, okay, now you're a surgical candidate. So politically, it depends where you're on the planet. And it's incredibly refreshing to see these surgeons in Germany employ the most conservative method with these patients first. If the conservative treatment doesn't work, the very successful conservative treatment, then they'll operate. And it would be nice if it was like that everywhere, but it's not. The machine should be shut down every day. And the reason for that is if you have a power failure, then the battery backup, of course, is going to work and it's going to be on. And then as the batteries diminish, then you're going to ruin the batteries in the UPS. And so just like leaving on older cars that didn't have the idiot reminders, if you left your headlights on older cars overnight, your battery was done in the morning. And depending on how flat these batteries go, these are also lead acid batteries, you can actually destroy the batteries. They become damaged and then you have to replace them. So rather than go through that at the end of the day, we shut it down. And the other thing is that happens sometimes, people just turn the power off. Because this is a Windows-based computer, you want to shut it down properly. And not just Windows, but you want the SpineMED application to shut down properly, and also the database. You'll see that when you go to shut it down, turn off, shuts down, it rebuilds all of the database indexes and closes it properly so that the database is properly indexed and closed down, and then the SpineMED application closes down as well. It shuts off, and then we turn off the UPS. Once Windows is finished shutting down, and you press that center button, hold it to hear a beep, which is about 2 seconds, like that, it's done. But it's still charging. So because that module, the power inlet module, still has that small switch on, the batteries are still being charged. One thing that I didn't talk about is reports. So on the Ultra system, while you have electronic patient charting, very comprehensive, where if you put your notes in, there's also reports. Again, SpineMED's been designed to save time in the clinic. Well, what we found in our clinics with the older style harness machines, we actually had to hire 1 or 2 extra practitioners to oversee the machine. It takes 10 or 12 minutes to put the harnesses on, then the setup, then you need them to be near the machine if the harnesses slip off. And so in the design of SpineMED, we were looking not only at clinical efficacy improvements, but also clinical efficiencies. So SpineMED's been designed to fit into a practice without the requirement of any additional staff. And I'm sure you fellows have found that. It's very quick, 90 seconds to set a patient up, you walk away. With harness style machines, it's not the case. And as well, so some of the other efficiencies, electronic patient charting, where we're recording all your notes electronically, and also reports, so that if you have a referring physician that's sending you a patient for treatment, you always want to send them some sort of follow-up so that you're keeping them in the loop. Or if it's an insurance company, PI or work comp, where you need to send a report. Built into the system is 4 different styles of reports. So to generate a report, touch a button, generates a report that can either be printed on the laser printer or exported as a PDF so that you can email it to the patient. And so depending on the length of your notes, that report could be 5, 10, 50 pages long, that you then send to whomever that you want to keep in the loop. So very time saving as well, rather than having a receptionist type out a report for you. It's all built in. It can be networked, as you fellows know.
Yeah.
So very few of the machines out there will share patient information. And so with the Ultra, you can network these. And one clinic here in Canada, he's got 7 machines that are all networked. So you can, when you bring a patient in, rather than saying, oh, this patient is only on this machine or that machine, and you have to adjust your schedule accordingly, that's another efficiency aspect of the device.